Thanks very much, Rinky. So, as Rinky said, I've been asked to give an overview, and I feel like the warm-up act, really, for Cleona's talk next, who's going to tell us actually the research that we're going to be doing. And to borrow Nina's phrase from earlier on this morning, I feel like I'm at risk of teaching you to suck kumaras, but we'll see how we go. So, we all know that there's an obesity epidemic worldwide, and this is one league table that New Zealand, frankly, doesn't want to be close to the top of, but sadly we are. We're on this slide at the bottom of. New Zealand here, based on 2007 data, and it hasn't changed on more recent data, sits at third place in the world in terms of rates of obesity, closely behind Mexico and the United States, and sadly beating Australia in this regard. These data are from the New Zealand Health Survey from 2014-2015, and just filling in a bit more from the previous slide, a third of adults in New Zealand are obese, and this is an increase from 2006. And a further third are overweight. So 2/3 of our population are either overweight or obese. That's the total adult population. But as you see from the slides here, and as we've been hearing about all of today, there are major inequities in New Zealand by ethnicity, and 47% of Maori adults are obese, and 66% of Pacific adults are obese. Not only is it an ethnicity issue, but it's also a deprivation issue as well. And so the most adults living in the most deprived areas of New Zealand are almost 2 times more likely to be obese. That's adults. The news is no better for children, and perhaps worse and perhaps even scarier, in the sense that 11% of children under the age of 15 were obese in 2014-2015, and that's an increase from 8% in 2006, so a faster increase. 22% of children are overweight, and similar figures here for Maori and Pacific, 30% of Pacific children being obese. And here the issues of deprivation are even stronger. So children living in deprived areas are 5 times more likely than their counterparts to be obese. This slide just shows that, some of that in a pictorial way, but also breaking it down by age groups, by decade, showing the prevalence of obesity, and perhaps not surprisingly showing that this increases with age. And also consistently that women are more likely to be, or have slightly higher rates of obesity than men. And again, showing pictorially the differences between our ethnic groups, predominant ethnic groups in New Zealand, showing the data there that I've mentioned in terms of Pacific, having rates up to almost 70% for women of obesity. You can distill that down by regions in New Zealand, and that sort of pulls together perhaps both issues of deprivation but also issues of ethnicity. And you can see on this slide that rates of obesity are highest in areas like Poverty Bay and South Auckland, having the highest rates, which shows both, as I say, the populations that live there, but also issues of deprivation. So pretty scary stuff. Why should we be even bothered about obesity? Can't we be fat and healthy? Well, obesity is, some people regard obesity as a disease in its own right, but there is no question that obesity is a very strong risk factor, and often the primary modifiable risk factor for many, many comorbidities. And these affect, we know about diabetes, we know about cardiovascular disease, but these affect multiple other systems and disease processes within the body, such as the obvious musculoskeletal issues. Cancer is not listed here as a separate entity, but we know obesity particularly increases the risk of certain cancers. But my area of interest, and this marries up with the National Science Challenge, is in the relationship between obesity and the increased risk of metabolic disease, insulin resistance, and diabetes. This slide, these are old data. These come from the United States, from their big, large epidemiological studies, but I think still serves to illustrate the point. as we gain weight and have an increased risk of diabetes, this is the relationship between body mass index and risk of diabetes. And we see here that for women with a BMI above 35, their risk of having diabetes relative to their lean counterparts is 90-fold. So obesity, a modifiable risk factor, is incredibly important in terms of metabolic disease and diabetes. We've heard about big data today, and this is a really good example, I think, of how it's been incredibly useful for us in New Zealand. These data are taken from the Virtual Diabetes Register, which is an example of this, and I'm very grateful to Emmanuel Joe and Paul Drury from the Ministry of Health for giving me the most up-to-date figures for this. And you can see here from the Virtual Diabetes Register the rates of diabetes over the last decade from 2005 through to 2015. And there's a steady and an ongoing increase in the rates of diabetes over that time. I'm going to take you through a series of slides, but just to illustrate the point at the beginning. This is age across the bottom here and percentage or prevalence of diabetes within each of these ethnic groups. The colours here are blue for European and other, red for Maori, orange for Pacific, and green for Indian. And what I think is really important to note from this slide is that we think of commonly and frequently about Maori having an increased risk of diabetes. But actually, in terms of ethnicity, the ethnicities that have the highest rates of diabetes are, in fact, Pacific and Indian. Maori have a significantly higher rate than European and close to the other ethnicities, but it is Pacific and Indian who have the highest rates by ethnicity. So these are the data from the end of 2006, taken from that Virtual Diabetes Register. And I'm just going to scroll through the years, and you can see visually what has happened in New Zealand. 2007, 2008, 2009, 2010, 2011. And so it's very obvious that the rates of diabetes have increased. They've increased mostly in the ethnicities who are at highest risk of diabetes, but also you will have seen a left shift of these curves. In other words, we are diagnosing diabetes, or people are developing diabetes at a younger age. And this mirrors the increase in obesity. I'm just going to skip forward to the most recent data, which is from 2015. And there's been a slight change in the way that the Virtual Diabetes Register has collected these data, and so therefore it doesn't marry up 100% with the previous slides that I've shown you. But again, it just serves to show you that there's been a further increase since 2011, and now at the ages of 70 to 74 for Pacific and for Indian people, it's up to 50% of the population for that ethnicity at that age group have diabetes. Scary. And that slide just shows you the comparison between 2005 and 2015. So I showed you earlier on the slide of New Zealand by region for rates of obesity. It's probably not surprising to you at all when I now show you the same graphical picture for the prevalence of diabetes, that the same areas are overrepresented. So if I haven't scared you enough already with the obesity epidemic and the tsunami of diabetes that's following it, what about this condition called prediabetes? And if you think of this as the iceberg, diabetes is what we see above the water, prediabetes is what is lurking below the water. Prediabetes in New Zealand is defined by HbA1c between 40 and 49 millimoles per mole. Of course, this is all a continuum, and we are putting lines in the sand at certain points, but we have to do that to serve a purpose. And I'll show you the data in a second, but 25% of the adult population in New Zealand have prediabetes. We're doing a fantastic job with the cardiovascular risk assessments that we've heard about. And from those, we are identifying people with prediabetes because we are doing an HbA1c in this group of people. But we haven't yet in New Zealand developed a systematic approach for how to manage those people at primary care level. And there's an urgent need for that. Why? Because prediabetes progresses to type 2 diabetes at a rate of 10% per annum, and eventually 70% of those who have prediabetes will develop type 2 diabetes in their lifetime unless something is done about it. And furthermore, prediabetes independently increases your risk of cardiovascular disease and also premature mortality. Just to show you a little more of the data around prediabetes in New Zealand, this is taken from Kirsten Capel's paper from the 2008-2009 Adult Nutrition Survey. It's the best data we've got for prediabetes rates in New Zealand. And what you can see here, this is for men. Here's the prevalence of diabetes by age group and the greater rates of prediabetes, and a similar but perhaps even bigger gap and scarier concept there for women. So an enormous problem. Now, I've chosen this slide to illustrate a point. I could have chosen a huge number of other studies and other slides. This is the Diabetes Prevention Program, which is a study which was conducted in the United States and took a group of people with prediabetes and randomized them to intensive lifestyle modification or to metformin or to placebo, and looked at the rate of progression to diabetes. And what you can see is that with intensive lifestyle intervention, there's a very significant 58% reduction in the progression to diabetes over the 4 years of the study. Now, the point from this is that we have evidence that lifestyle intervention makes a difference. There are other studies which have shown exactly the same point and exactly the same data. So, New Zealand, we've got a major problem with obesity. Type 2 diabetes is increasing on the back of that. There is a significant differences between ethnicities in New Zealand, and we have a major iceberg with a problem under the water of 25% of the population having pre-diabetes. We know diet and lifestyle interventions can work, but we have failed, and it's not just in New Zealand, we have failed to translate that evidence, and this point's been made repeatedly this afternoon, to translate that evidence we know into the real world and to actually make it work. So where are the gaps then in the research, and where are the gaps that the National Science Challenge hopefully can address? So it's finding effective translation of that existing evidence, and particularly focusing, I think, on the pre-diabetes population and preventing them progressing onto type 2 diabetes. It's also looking at ways to effectively engage all of New Zealanders in this, so that we, and again we've heard a lot about this today, do not increase inequities, that we actually bridge that gap, and to encourage self-management, otherwise we'll bankrupt the country. We also have to focus on trying to understand more what actually underpins the differences between ethnicities, not only in terms of their risk of developing obesity and diabetes, but also ways to manage that for them, particularly as individuals. And finally, I think we need to acknowledge that it would be useful to have novel therapies as well to help prevent the progression from prediabetes to diabetes. So thank you very much.